You can see that myself and soon to be Dr. Betcher were the writers of this particular course, and there is quite a bit to get through. Supraspinatus is a fun little muscle. All right, so we'll do a little introduction. We'll talk about the location. We will talk about action.
It's a joke.
Hey guys, please make sure your audio is turned to mute. We go over actions and function, fascia and subsystems, electromyographic research, movement impairment in the supraspinatus, trigger points and referral pain, and a sample intervention. As you know, we're really big on trying to make everything we talk about practical. So starting off, let's talk about etymology. Etymology is where the words come from, right? Attachments and innervation, and relative size and fiber type. So etymology, let's talk about rotator cuff. So obviously rotator cuff comes from the words rotate, right? Which is what it sounds like, rotate, and cuff being the head or covering of something, the bottom of the sleeve. So rotator cuff is literally referring to a covering that rotates. And for those of you guys who know a little bit more about anatomy, we know that the rotator cuff is a group of muscles that covers the humeral head and will rotate the humeral head. We have the supraspinatus broken down here. So supra is a word forming element that means above. Okay. Spine refers to the backbone, and natal, as in natus, natal, is of or pertaining to or the birth or origin of something. And you guys can see here that the supraspinatus is above the spine, this long lateral ridge here of the scapula. The origin of the supraspinatus, the proximal attachment invests in the medial 2/3 of the supraspinous fossa of the scapula. The supraspinatus literally has its own fossa, is a fancy word for depression, right? So that entire depression there above the spine of the scapula is there for the supraspinatus. The distal attachment, this gets just a little complicated, but you see invests in the superior facet of the greater tubercle at the head of the humerus and the superior joint capsule. That sounds worse than it is. You guys can see the red arrow here in the picture. The greater tubercle is the larger bump. It is the medial bump of the humerus. The lateral bump of the humerus, the more lateral bump of the humerus, and you can see it connects to the superior portion of that large bump. And if you saw the rest of the anatomy of the shoulder, which obviously has been removed in this picture, you'd see that the tendon of the supraspinatus also blends with the shoulder capsule. The supraspinatus is innervated by the suprascapular nerve. Now, the suprascapular nerve arises from the upper trunk of the brachial plexus via the ventral rami of nerve roots C5 and C6, and occasionally C4. Now, for some of you guys that may not matter very much, for my clinical professionals, that does have some clinical implications, like if somebody is weak in abduction and we think the supraspinatus may be involved, sure, it could be a problem with the supraspinatus, but it could also be a problem with the neck. If we have some cervical dysfunction that's interrupting the electrical signal to the supraspinatus from the neck, right, we can also have some supraspinatus dysfunction. And if we know a little bit about the supraspinatus, we would even be able to implicate that maybe it is C5 and C6 and potentially C4 where that dysfunction is occurring. The suprascapular nerve does pass through the scapular notch, which you guys can see in this picture. It has suprascapular, and then it has that line that's pointed to the suprascapular nerve. And then right underneath that, you see that notch. So the suprascapular nerve goes over that notch and underneath the supraspinatus. Once it goes underneath the supraspinatus, it actually travels underneath the supraspinatus and around the spine of the scapula laterally, and then connects into the infraspinatus, right? So you can kind of imagine that pathway of that nerve, as you can kind of see in that picture. And both the suprascapular notch and where it comes down into the wraps around the spine of the scapula there are places where you may have some nerve impingement, although it is pretty rare. All right, so let's talk about muscle size and variations. The supraspinatus is a relatively small muscle, contributing approximately 2% of the total mass of the muscles of the upper body. To give you a comparison, the pectoralis major is 11%. You can see here rotator cuff muscle size comparisons. The subscapularis, which we went over in a previous webinar, is 6.6% of upper body muscle mass, whereas the supraspinatus is just 2%. The subscapularis, you can see, is almost as large as all of the rest of the rotator cuff muscles. Fiber type. 2 studies demonstrate that the supraspinatus is primarily type 1 muscle fibers, approximately 60%. That's actually not that uncommon for the human body. I think a lot of muscles we see are more type 1 than type 2. It's pretty rare that we come across a muscle that is more type 2. I know we get taught in school that, like, if you're powerful, you're type 2 dominant, and if you're, endurance, you're type 1 dominant. It doesn't quite work out that way. The differentiation in fiber type is not as big as you might expect, and obviously certain muscles will always be more type 1 than type 2, for example, the supraspinatus here. All right, so some location here. The supraspinatus lies deep to the upper trapezius with the tendon covered by the acromion shelf. All right, so it's inferior to the supraspinatus. Sorry. So underneath the upper trapezius, the tendon goes underneath the acromion shelf. Inferior to the supraspinatus is the supraspinous fossa and the subscapular notch, which we just talked about. So you have trap, supraspinatus, and then underneath that is the supraspinatus fascia and scapular notch. The suprascapular nerve we talked about passes underneath the supraspinatus, right? And I kind of talked about how that pathway goes from the suprascapular nerve underneath the supraspinatus and then around the spine of the scapula into the infraspinatus. The suprascapular artery passes deep to the supraspinatus as well, although rather than going through the supraspinatus notch like the suprascapular nerve does, there's actually a transverse ligament over that notch that kind of like makes the top of the scapula a straight line. For some reason, the artery actually goes over that ligament. All right, so from the insertion, this is where things get really kind of funky. Laterally, the tendon of the supraspinatus runs underneath the acromion shelf. So you guys should know your acromion shelf is that bony ridge just above your deltoid. Your supraspinatus goes under that. Between the infraspinatus tendon posteriorly and anterior, the fascial web of the subscapularis tendon, superior and middle glenohumeral ligaments, coracohumeral ligaments, and the transverse humeral ligament. This tendon inserts into the periosteum of the superior facet of the greater tubercle, as well as the superior joint capsule. All right, so basically what we're saying here, guys, is the supraspinatus lies anterior to, So it lies anterior to the infraspinatus tendon, right? So basically what this is saying is the external rotator tendons are behind the supraspinatus. And then you guys can kind of see here, there's like this fascia, this white stuff. That fascia is actually contributed to by a bunch of different structures. Okay, the coracohumeral ligament, the transverse humeral ligament. We even see later that like the pectoralis major contributes to that fascia. So the shoulder fascial network around the capsule is a little complicated. The supraspinatus is kind of like on top, external rotators behind, and then all of this anterior stuff. Palpation. With your partner in prone lying position, so your partner laying face down in front of you. If you turn their head facing away from the side you want to palpate, and then move the head towards the side you want to palpate, this is going to help with your palpation by putting the upper trapezius muscle on slack. Remember, the supraspinatus is underneath the upper trapezius. So the first thing we want to do to make it easier on our fingers is turn the head away, right? Because the trapezius rotates away and then ipsilaterally flexes to the same side. So all we're going to do is do that passively to shorten the muscle, but without them actively contracting, that'll just make it all soft. Okay? You're going to locate the spine of the scapula and press caudally through the trapezius. Right? Caudally is like towards the tail, towards their tailbone. So down through the trapezius, toward the spine of the scapula until your fingers rest in the supraspinous fossa. If you place your other hand on their humerus, what you can do is if you have them lightly abduct into your hand and you're in the supraspinous fossa, you will be able to feel the supraspinatus contract, get dense underneath your fingers. Now you got to be careful. If you have them abduct really hard, they'll go into elevation or upper rotation of the scapula and their trap will contract. But if you just do a little abduction and make sure that they're keeping their shoulder blade down, you'll be able to feel those supraspinatus fibers contract into your finger. Same way like if you put your hand on your bicep and you contract, right? Like you flex, right? Like you'll get that same sort of feeling in the supraspinatus. All right, osteokinematic joint actions, integrated function of the supraspinatus, and arthrokinematics. So what does the supraspinatus do? Well, it does shoulder abduction, right? You know, this is a frontal plane motion, right? That raises the arm up. Abduction, actually, the definition of abduction is to go up away from the midline of the body. Okay, so abduction is away from the midline in the frontal plane. That's what this muscle does. Now, the supraspinatus was thought to play a larger role in initiating this motion, but the research doesn't actually demonstrate that. The supraspinatus, more or less, functions, shows the same amount of EMG activity as the deltoid muscles. Now, as far as stabilization, the supraspinatus will help stabilize the humeral head. And as far as what it eccentrically decelerates, right? So what it will slow down. Obviously, we know that all muscles will eccentrically slow down the opposite joint action that they do. So if the supraspinatus does abduction, it will slow down adduction. Synergists. Okay, so integrated function now we're talking about. During shoulder abduction, the middle deltoid is the prime mover and the supraspinatus is the synergist. Okay? So all we're saying here is the supraspinatus is not the prime mover. Although it will do abduction, it never is the primary abductor. The deltoid is the primary abductor, which is not surprising. You know, the deltoid is much, much larger than the supraspinatus. As part of the rotator cuff, the supraspinatus, infraspinatus, teres minor, and subscapularis contribute synergistically to dynamically stabilize the glenohumeral joint. For those of you guys who've done a little bit more study of anatomy, you might know that like calling the shoulder a ball and socket joint is a little generous. It's more like a dish and huge humeral head, and then the rotator cuff muscles come in there to hold those two things together. Now, arthrokinematic motion, this always tends to get students a little mixed up, but all we're talking about is the small motions that help keep joint surfaces congruent. Okay, so there's only a few of them. People tend to get really confused about these as if there's a bunch, kind of like the osteokinematic joint actions, which are abduction, adduction, internal rotation, external rotation. But these are the smaller motions: roll, glide, spin, and distraction, right? That's all that we can do, right? So it's either rolling like a ball, gliding, like we might be able to do, like if you imagine a pool ball on a pool table, this really helps. So rolling would be just what it sounds like rolling. Gliding would be gliding across the table without rotation, right? Spin would be spinning like a top. Compression would be being pressed into, the distraction would be being pulled away from that surface. All right, so what does the supraspinatus do? Well, the supraspinatus, based on its fiber direction, is probably going to help with superior glide of the humeral head, right? As well as compression. Now, there might be an argument be able to be made for inferior glide of the humeral head. I call this the juice box function. Right, you guys remember juice boxes? Like when you were a kid, you put a little straw on top, and then to get liquid out of the top, where would you squeeze? The top of the box or the bottom? The bottom of the box, right? So, although hypothetically the joint or the directions of pull of the supraspinatus should help with superior glide and compression, if the supraspinatus was short, you could also see where it would compress and kind of force inferior glide via that kind of juice box analogy. Now, which one of those actually occurs? Good question. Right? This is one of those things, it's a little bit of a gray area in the research. I can tell you that inferior glide is what contributes to shoulder dysfunction or is correlated with shoulder dysfunction. Believe it or not, it is not excessive superior glide that is associated with shoulder dysfunction. All right, so let's get into some fascia stuff. I know this was a really, really big deal at one point, and we saw a bunch of, sorry guys, hold on one second. We saw fascia really get a lot of attention over the last 10 years. We used to think that fascia was this completely passive tissue, that it supported, protected, stored some elastic energy, right, and transmitted force from muscle to bone. Now we know that it's highly innervated with nerve endings. It's arranged in layers that slide over each other. They transmit tension between muscles, okay? And they transmit the force of multiple muscles to aid in stabilization of joints. Now, let's talk about fascial integration of the supraspinatus from the perspective of the origin of the supraspinatus. So that's in the supraspinous fossa now. The supraspinatus is enclosed within its own fascial compartment, separated from the upper trapezius by the supraspinatus fascia. It's a nice convenient naming. So we have the supraspinatus covered by the supraspinatus fascia. Nice. The supraspinatus fascia is continuous with the infraspinatus fascia. So that's the fascia covering the infraspinatus, this nice large external rotator below it. However, these muscles are separated by the spine of the scapula, which, if you guys know your anatomy, kind of already knew. Right? Further, the supraspinatus fascia has some continuity with the levator scapula. This actually makes a little bit of sense, right? So the trapezius is over the supraspinatus. The supraspinatus and levator scapulae are both under the upper trapezius, so their fascia is a bit more continuous. And then, of course, that continues into the prevertebral layer of cervical fascia. Cervical fascia is a little complicated. You can definitely go down a rabbit hole on that one. Okay, so now we're talking about from the perspective of the insertion. The supraspinatus tendon blends with the shoulder capsule. This is kind of what we talked about before. You guys might actually have already put that together. The supraspinatus blends with the superior shoulder capsule, right, because it is on top, between the more posterior infraspinatus and teres minor tendons, which we talked about, and the more anterior inferior fascial web and inferior fascial web created by the subscapularis tendon, superior and middle glenohumeral ligaments, coracohumeral ligament, and the transverse humeral ligament. And so there is a bunch of stuff that kind of comes together in that interior fascial web. Additionally, the long head of the biceps brachii, the long head of the triceps brachii, and pectoralis major invest in the shoulder capsule. So then you start thinking, well, if fascia is densely innervated with nerves, and all of these muscles can contribute to the amount of tension in this fascial structure, you start to play this game in your head where you can see all of these muscles both contributing to shoulder capsule stability and tension during motion, as well as it's not too far to think that maybe tension in this fascial system starts giving us feedback to our central nervous system and creates some reflex arcs that may contribute to ideal recruitment. All right, so electromyographic research. This is where I get really excited. Things do get a little technical. So let's all put our thinking caps on, get ready to take on some detailed information. All right, so healthy individuals in supraspinatus EMG activity. The supraspinatus is likely to exhibit higher electromyographic activity during external rotation than internal rotation, but more activity during prone horizontal abduction at 100 degrees with full external rotation. Further, EMG activity is likely to increase with increased load. All right, so supraspinatus activity, let's kind of put this all together. Higher during external rotation than internal rotation, so not as active during internal rotation. But if I do this exercise, right, which would be the T of ITYs, so some of you guys probably do ITYs, right? If I do this T thing with full external rotation, I get even more activity than just external rotation. Flexion, extension, and abduction. You know that supraspinatus EMG activity will increase with increases in load for all of those joint actions, actually. So despite the fact that the supraspinatus might not contribute to internal rotation or contribute to extension, we do see an increase in EMG activity when we load those joint actions. Remember, your supraspinatus is part of your rotator cuff, and it's going to help with dynamic stabilization of the shoulder. It is likely, so again, we get this confusing mismatch of joint actions here, right? So we can imagine that abduction is probably the thing that's going to get us the most EMG activity, but then we have external rotation more than internal rotation, but then we have flexion more than extension. And then we can add a little detail to abduction here by saying that the supraspinatus is actually more active at 90 degrees than it is at anywhere else of the arc of abduction. So that last bit, and this is just, guys, this slide is just condensing all of the research, EMG activity research, which you can read on the course. But all that last slide is saying, again, is you just kind of see this general theme in the research of horizontal abduction with full external rotation generally results in the largest EMG activity when we're comparing various exercises. Isometric positions, as we just mentioned, 90 degrees of isometric abduction. So now we're talking about if you hold in different positions, what causes the most EMG activity, and we see 90 degrees of abduction is where we see the biggest spike in EMG activity for the supraspinatus. All right, so healthy, okay, so passive and active assisted motions. This is probably more important for those of you guys who are looking at post-surgical patients, okay, because we end up starting with some of those passive motions and active assisted motions. Well, we kind of need to know, depending on what surgical procedure has been done, what passive and active assisted motions are going to result in the most activity, right? Like if we had a supraspinatus tear, we might initially want to stay away from passive and active assisted motions that cause a lot of EMG activity, that could be a little rough, right? So you see the passive and active assisted shoulder motions increase subscapularis EMG activity significantly more than supraspinatus EMG activity. So that's kind of a good thing to know. If, for example, the subscapularis was intact prior to surgery, you're probably a little in the safer realm with these passive and active assisted ranges of motion. Now, if you have a subscapularis tear, that could be a problem. However, passive and active assisted shoulder flexion significantly increases supraspinatus EMG activity. All right, so that is something to keep in mind. The highest supraspinatus EMG activity may be exhibited when performing active assisted flexion on an unstable surface, so things like stability ball rollouts, or during combined joint actions and end range activities. And anybody who's done post-surgical rehab, you know things that like putting on a shirt, putting on a jacket, putting on a sweater, those type of things for the shoulder can be really, really challenging post-surgical. As far as sport, the supraspinatus may be more active during the eccentric phase of throwing and serving, right? So if we're talking about tennis, but may also be more active during concentric motions that include shoulder external rotation and flexion. So again, we're kind of doing this sort of motion. The supraspinatus does get involved a little bit there. All right, so what happens when we get dysfunction? So now we have shoulder dysfunction. We know that there's different EMG activity changes throughout the shoulder girdle. What happens to the supraspinatus? Well, in shoulder impingement syndrome, we see a small increase in the amount of supraspinatus EMG activity, average supraspinatus EMG activity. However, that small increase, when you compare it to the general decrease in activity of other shoulder muscles, is probably pretty significant. You have basically overactivity of the supraspinatus, even though it's only small in the research, compared to everything else, not so small. Comparing abduction, flexion, scaption, and external rotation, it is important to realize that when we say things like supraspinatus is overactive, that when we look at the research, that may not pan out for all joint actions. Because we see a compensation pattern leaning towards overactivity, doesn't mean that, for example, during external rotation, we're still going to see supraspinatus overactivity. It might not be more active during external rotation, but maybe way more overactive during things like flexion and abduction as we kind of started stacking our understanding of how this muscle functions. Daily activities and throwing. Shoulder dysfunction may increase supraspinatus EMG activity during lifting at all phases of the pitch. Okay? Conversely, dysfunction is unlikely to detailed EMG activity and may decrease the activity of the pectoralis major, subscapularis, latissimus dorsi, and serratus anterior. So again, we see this thing happening where when people end up with shoulder dysfunction, you have this slight increase in supraspinatus EMG activity while everything else decreases. Well, you can imagine the additional force and the additional stress that places on the supraspinatus. All right, so movement impairment and postural dysfunction, clinical implications. All right, so signs correlated with upper body dysfunction, arms fall, and shoulder girdle elevation during an overhead squat assessment. Now, for those of you guys who don't know what the overhead squat assessment is, please take those courses. This is kind of our top tier assessment, the thing we start with, and there's good reason to start with that assessment. It's a great general assessment to get an overall view of what's happening with the human movement system. Okay? Now, if somebody has upper body dysfunction, we just read the research that kind of shows that this is likely to lead to supraspinatus overactivity. Now, it probably contributes to arms fall, the supraspinatus that is, to arms fall by restricting end range shoulder flexion. And you're probably thinking to yourself, but the supraspinatus doesn't do shoulder extension. And that's true, but we don't always have to have the muscle that restricts a joint motion to restrict it based on osteokinematic motions alone. Chances are that the supraspinatus is going to affect shoulder range of motion by disrupting arthrokinematics. Right? So too much compression, either superior or inferior glide, whatever the answer to that question is once we get the rest of the research, right? So we end up with these excessive arthrokinematic motions that end up restricting our osteokinematic motions, right, like flexion, and then we see something like arms fall on an overhead squat assessment. As an abductor of the shoulder, this gets a little tricky. As an abductor of the shoulder, realize that relative abduction, if we held the humerus in place, would be scapular downward rotation. So regardless of whether I do abduction of the shoulder or downward rotation of the scapula, the supraspinatus is going to decrease in length. So we could say that supraspinatus overactivity is also likely to contribute to scapular downward rotation, or we could say that scapular downward rotation is likely to result in shortening and overactivity of the supraspinatus. Application. Identification of these signs implies that the supraspinatus should be addressed with release techniques. Right? So we use release techniques, things like ischemic compression, right, trigger point release, to help decrease activity. Now, I made a special note here. A lot of you guys probably learned that short and overactive means you release and stretch, and that's right. But practically speaking, there's no real good way to lengthen the supraspinatus. You can't pull your humerus through your torso. And so you might get some lengthening doing something like a shoulder mobilization technique, which is distraction. You know, the supraspinatus aids decompression. So if we distract a little bit, that might help to lengthen. All right, so what are the clinical implications? This is correlated with changes in supraspinatus activity, right? So shoulder impingement syndrome and shoulder pain, shoulder instability, anterior capsule laxity, supraspinatus trigger points, bursitis, rotator cuff tears, osteoarthritis of the glenohumeral joint, neck pain resulting from scapular dyskinesis, and suprascapular nerve entrapment are all clinical implications that the supraspinatus could be involved. In short, if you have upper body dysfunction, the supraspinatus may be contributing somewhere. All right. So what do we do with our assessment? So if you see arms fall on your overhead squat assessment, the supraspinatus is likely overactive. Shoulder internal rotation, less than 70 degrees, likely overactive. Shoulder external rotation, less than 90 degrees, likely overactive. Shoulder flexion, less than 180 degrees, overactive and short. Okay. So what we're basically saying here is, supraspinatus technically only contributes to abduction. And you would think that, well, if it shortens, the only thing it's going to restrict is adduction. That makes logical sense from an osteokinematic standpoint, but what that doesn't consider is how this supraspinatus could affect arthrokinematics and the alignment of the humeral head with the glenoid fossa. And what we kind of see is when the supraspinatus gets overactive, we kind of end up with this like shortening or this limitation in potentially any range of the shoulder. You're just not going to get optimal range if the supraspinatus is not doing what it's supposed to do. Some of you guys might be using the Apley scratch test, and inability to reach T7 on the opposite superior angle of the scapula may indicate supraspinatus activity, and obviously from the bottom arm, the inability to reach T7 or the opposite inferior angle. Now, obviously the model in this picture has great mobility of her shoulder girdle, so we would not be considering this an indication of supraspinatus overactivity. All right, trigger point locations. All right, so the common sites for trigger points in the supraspinatus are just lateral to the vertebral border. All right, so you guys can see that X that's more medial. Right, so if I stayed in the supraspinous fossa and went all the way towards the spine as far as I could go, that's one place. And then and then kind of deep to the upper trapezius, kind of in the middle there, in the middle of the muscle belly, you see another common site for supraspinatus trigger points. The referral pattern is actually radiating down the lateral deltoid, could radiate all the way down to the lateral epicondyle, and then the side of the forearm. I can't tell you guys, like I see a lot of people get pain in the middle deltoid, right? I see this in the gym more, right? So they get pain in their middle deltoid, sometimes even their anterior deltoid, and they like try to foam roll their deltoid. Sometimes they put like a foam roll up against the wall or something. Generally speaking, your deltoids are not a common site for trigger points, but your supraspinatus is. Generally, that side deltoid trigger point-like pain is a referral pain from the supraspinatus. So learning how to release your supraspinatus is definitely a good idea for those of you guys in clinical practice. Learning manual release for the supraspinatus is definitely a great idea. We discussed how to palpate that at the beginning of this webinar. Release techniques, by the way, are just palpating a dense nodule and holding it. It's not a very complicated thing. You just have to have some good palpation skills. All right, so what are the recommended interventions? Well, we have release and mobilization. As we talked about, you're not going to lengthen the supraspinatus, but shoulder mobilization may be helpful. And we have both self-administered and manual techniques for the supraspinatus. And then, of course, for shoulder mobilization, there's self-administered shoulder mobilization and manual shoulder mobilization. Right, so if I'm going to try to affect my supraspinatus, these are the techniques I'm thinking about. Addressing arms fall. So let's say we have an individual who has arms fall on the overhead squat assessment. What does this end up looking like in an actual intervention plan? Well, if you're talking to us at the Brookbush Institute, we're trying to essentially create a system of the most effective techniques to ensure that we're getting the most reliably highest effect size outcomes we possibly can. Right, so that ends up combining release, mobilization, and lengthening. That's our mobility techniques. And then we have to activate on the other side, right? So we need to activate those underactive structures and then integrate them into some sort of movement pattern so we keep training the body to start moving the right way. If I have arms fall, this is a very common protocol that we might use, right? So you can see we do supraspinatus static release, right? We do subscapularis static release, we do posterior deltoid static release, pectoralis minor. Right now we're kind of getting some of those overactive muscles less active. If somebody is hypomobile, they have a reduction in shoulder mobility, we can do that shoulder mobilization technique. Be careful. If somebody is hypermobile, the last thing you want to do is a shoulder mobilization. For lengthening, we can do child's pose. And so child's pose is a great stretch and deflection, which is going to affect things like your latissimus dorsi, your teres major, even your pectoralis minor. Activations, so external rotators of the shoulder have a propensity to get underactive. The serratus anterior definitely has a propensity to get underactive. The lower trapezius with standing cobras here has a propensity to get underactive. And then what do we do for integration? We do the suspension row. And so we do just like this nice pulling. And hopefully now that we've kind of influenced all of the activity and length of these structures, hopefully now with this suspension row, we're getting really good movement patterns and we can start strengthening and reinforcing this new thing. And there you guys go. That's the supraspinatus in a nutshell.